In this video, we will discuss the endocrine system. We'll just do a quick overview, talk about some chemical classification, and then talk about some specific endocrine organs and the hormones they make and how they work. So, endocrine glands are defined as being ductless, and what they do is they secrete their products directly into the blood. So everything that is produced by these glands are hormones, and hormones are just chemical messengers that are going to bind to receptors on cells or organs that have those receptors, and that is going to cause a change in that cell. It's going to impact some chemical process within that cell. So quickly, there is a way to chemically classify hormones based off of what they are made out of. So for example, amines. Amines are produced from tyrosine or tryptophan, and examples of these would be norepinephrine and epinephrine, which are both produced by the adrenal medulla, T3, T4 by the thyroid gland, and these are hydrophobic. Polypeptides and proteins, as you know, these are chains of amino acids, and examples of these would be antidiuretic hormone, growth hormone, insulin, or glucagon. Glycoproteins, it's in the name. Glyco means carbohydrate. Protein means a protein added. And examples of these would be luteinizing hormone, follicle stimulating hormone, or thyroid stimulating hormone. And then we have steroids. And steroids are lipids that came from cholesterol. And because they are lipids, they are hydrophobic. So some examples of these would be cortisol is a good example, testosterone is another example, estrogen and progesterone. So this is showing you how steroids are made. And as you can see, cholesterol is a precursor here. But something that's interesting is that notice that progesterone is a common precursor to a lot of these other steroid hormones that we have. Testosterone is another, precursor to another hormone, estradiol, which we have in the ovaries. So hormones are going to interact with each other, and they can do it in different ways. They can add together and complement to each other to make a bigger effect. An example of this would be the hormones epinephrine and norepinephrine and their effect on increasing the heart rate via sympathetic activation. Hormones can be permissive of one another, which means that they can increase their effect of one, can increase the effect of the other, or enhance the responsiveness of another. An example of this is that estrogen is needed for oxytocin production. And then another way that hormones can interact is antagonists, and we're going to see a few examples of these today too. And this is where they may inhibit the effect of the other, or they're going to do the opposite effect of another. So an example of this is insulin and glucagon on fat cells. And another example would be like calcitonin and parathyroid hormone. And so we'll talk about a few examples of all of these, I think. The effect of hormone depend on how much hormone is in the blood. So the concentration of hormone in the blood. And, the body wants it to maintain at a healthy range, and abnormally high concentrations may have bad side effects. An example of this is when male athletes can take large doses of anabolic steroids, and bad side effects can occur, like breast tissue, erectile dysfunction, increased risk for heart disease. So this increased dose of anabolic steroids can actually increase the amount of estrogen in the body, because remember that figure that I just showed you about how testosterone is a precursor to estradiol. To kind of control this, there can be upregulation or downregulation of receptors. So for example, when there is a high concentration of hormone, there can be a downregulation of receptors. And so it's almost like there's a desensitization of the tissue. An example of this would be in adipose cells that are exposed to high insulin concentration for a long time. What's going to happen is there's going to be downregulation of receptors, which means there's going to be a reduced amount of receptors so that it won't respond to even the high concentration of insulin. And what that's going to do is that's going to decrease the effect of the hormone on the target. So again, we want the hormones to maintain a normal, healthy range, and anything outside of that is going to have either bad side effects or can be up-regulated or down-regulated. So now we're just going to talk about a couple endocrine organs and their products. And so first we're going to start with the pituitary gland. And so hopefully this is review for you. Here is our pituitary gland down here, and you have your anterior pituitary as well as your posterior pituitary. And the main takeaway here is that notice that the posterior pituitary is really the extension of tissue from the hypothalamus. And so the hypothalamus and the pituitary gland are really close together, really connected, but this posterior lobe is made out of neural tissue, whereas this anterior lobe is made out of that simple cuboidal, typical endocrine tissue. The posterior pituitary is working really closely with the hypothalamus. The hypothalamus is going to, we will see that the hypothalamus produces a lot of hormones on its own, but two that are relevant to the posterior pituitary here are antidiuretic hormone and oxytocin. The posterior pituitary, the hypothalamus produces antidiuretic hormone and oxytocin. However, it gets released by the posterior pituitary. If you can remember from previous lectures, antidiuretic hormone is in times of when you're not drinking water. And what it's going to do is it's going to increase water absorption in the kidneys by increasing the number of aquaporins in the collecting ducts. And then it also causes uterine contraction during labor. And so maybe you've heard of women who are injected with Pitocin during labor. Pitocin is synthetic oxytocin. Pitocin is synthetic oxytocin. And what it does is it's to induce labor. Say if you've gone past your due date, or if maybe the fetal membrane, like a lady's water has broken, that can possibly lead to infection if the baby doesn't come out within 24 to 48 hours. And so doctors may inject Pitocin to kind of induce labor to continue. Other reasons why this may occur is because of preeclampsia, which is a condition that mothers may get, especially in older age, and that can cause high blood pressure. And so all of those doctors would want to induce labor. Pitocin can also be given after delivery to continue those uterine contractions, to reduce uterus size, and also to reduce blood flow or prevent hemorrhage. The anterior pituitary, so we've discussed the posterior pituitary and the hypothalamus and how they secrete ADH and oxytocin. And then the anterior pituitary is going to produce 6 hormones that we will discuss. First off, we have growth hormone. And growth hormone, just like its name, it stimulates growth. Stimulates growth of bone, stimulates growth of cartilage. It also stimulates protein synthesis and movement of amino acids. Thyroid stimulating hormone, just like its name, it's going to stimulate the thyroid to produce hormone of itself. So it's going to stimulate thyroid to produce T3, T4. And then just like its name, adrenocorticotropic hormone, it's going to stimulate the adrenal cortex to produce the hormones that it produces. And we'll talk about these. It produces cortisol and aldosterone. So the anterior pituitary is really considered kind of a master endocrine organ because it's kind of like it controls other endocrine organs. It controls the thyroid, it can control the adrenocorticotropic hormone, it can control the adrenal cortex. But really, what we're going to see is that the hypothalamus is kind of the master here because the hypothalamus controls the anterior pituitary. Follicle stimulating hormone, just like its name, it's going to stimulate follicles. And so what that means is it's going to stimulate ovum and sperm production. Luteinizing hormone is what causes ovulation. We see a spike in this when females ovulate during their ovarian cycle. And this is also going to stimulate secretion of testosterone by the interstitial cells in the testes. And then lastly, prolactin, which, along with prolactin is going to stimulate milk production, and then oxytocin stimulates milk ejection. So just some clinical disorders or clinical examples here. Here we have 2 disorders of growth hormone, and these are both in childhood, and that's an important part here, in childhood. And this is called pituitary dwarfism. If you didn't know, there are many different versions or many different types of dwarfism. And then on the right here, we have gigantism, and this person's over 8 feet tall. And this person over here is about 2 feet, maybe 2.5. This whether there is hyposecretion or hypersecretion in childhood or in adulthood does matter. And as we see here, in adulthood, hyposecretion in adulthood but not childhood provides for a fully grown man, a fully grown person. However, they may be malnourished. And so this is called Simmons disease. Their bones and tissues are not growing as they should. And then hypersecretion is shown down here and it's called acromegaly. And so this is the before picture and this is the after picture. And so what we see is, long bones can no longer get longer here. And so what happens is flat bones get wider. And you can see it in the jawline of this individual's face. So if you've ever watched the movie Princess Bride and you know who Andre the Giant is, Andre the Giant kind of had a similar face to this man. And that's because Andre the Giant also had, this is not Andre the Giant, Andre the Giant also had acromegaly. So as I said before, the anterior pituitary used to be called the master endocrine organ, but really it is the hypothalamus that controls all of it. The hypothalamus uses releasing or inhibiting hormones that are produced by the neurons here in the hypothalamus, and they're carried via this hypothalamo-hypophyseal portal system. And so these hormones are shown with these little green balls, and they are going to stimulate the anterior pituitary to secrete their hormones, and these are shown with these pink. So don't worry about remembering these names. The main idea here is that you understand that really what controls the anterior pituitary is the hypothalamus. And so it's actually wrong to call the anterior pituitary the master endocrine organ. It's almost like we should call the hypothalamus the master endocrine organ, even though it is a neural structure. So in this image, we have the hypothalamus releasing a hormone called thyrotropin releasing hormone, and that is going to stimulate the anterior pituitary to produce and release thyroid stimulating hormone, and that is going to stimulate the thyroid to release its hormone called thyroxine. This concentration of thyroxine is going to inhibit the anterior pituitary's responsiveness to the hypothalamus TRH, which is going to prevent it from producing more thyroid stimulating hormone, which would be negative feedback. So the hypothalamus is a neural structure, and it integrates what it receives from higher brain centers like the cerebral cortex, and that can affect the anterior pituitary secretion as well. So that means that the emotional state or psychological stress can impact menstrual cycle, adrenal hormones, circadian rhythms that are all dependent on hormone release. Thyroid hormones are released by the thyroid. Notice where it is. It's directly inferior to your thyroid cartilage. And it's made in thyroid follicle, which I'll show you on the next slide. These thyroid hormones, also called T4 and T3, and they're called that because they require 4 iodines or 3 iodines. They set our basal metabolic rate. So what that means is it increases the rate of metabolic processes in the body. They can increase protein synthesis, and they are required for growth and development. So this is an image, a drawing of a follicle, if you can remember from human anatomy. On the outside, we have our simple cuboidal follicular cells, and on the inside, we have that precursor to the thyroid hormones called colloid. And so what happens, or what's shown here, is that the ion iodide is taken in from the plasma, and then remember that T3, T4 hormones are amines, and they are hydrophobic, and so they require the use of a plasma carrier protein to be secreted within the plasma. Some clinical disorders of the thyroid hormones, maybe you've heard of goiters, which is shown in this image right here. What a goiter is when an individual has low T3, T4 because of iodine deficiency. And so what happens is the reason why a goiter occurs is because those follicles continue to want to produce T3, T4. There is an excess of thyroid stimulating hormone from the anterior pituitary, and this is going to have an overgrowth of thyroid tissue. And so this doesn't happen in the United States because we have a well-rounded diet, but in third world countries, this is something that can be an issue if iodine is not a part of their diet. And so what we have for us now is fortified foods such as iodized salt, and that is why it's to prevent these goiters, and to allow for T3, T4 to be produced. Cretinism is another form of hypothyroidism, and this is in fetal development or in babies. And because this is required for growth, this can cause severe mental retardation. Hyperthyroidism is caused by excess T4 secretion. And this can cause a high basal metabolic rate, so high, maybe unable to sleep, high heart rate, weight loss, nervousness, irritability, anxiety, intolerance to heat. And so Graves' disease is what Wendy Williams and Missy Elliott have, and it's actually an autoimmune disease. Antibodies are going to have thyroid-stimulating hormone-like effects, which is going to cause that excess T4. So excess stimulation of the thyroid, and it's not inhibited by negative feedback. Another side effect of this is called exophthalmos, which is the bulging eyes. The parathyroids are these 4 nodules on the posterior side of our thyroid gland. There's just these 4 little bumps, and they secrete a hormone called parathyroid hormone. And what it does is it controls blood calcium levels. When blood calcium levels are low, the parathyroid hormone is secreted, and what will happen is bone will get resorbed, and this will increase blood calcium. This will decrease bone density. Another way it works is that it will increase absorption of calcium within the kidneys. So that's a second way to do that. And that will mean that less calcium is excreted during urination. And this increased blood calcium is going to cause a negative feedback effect on the parathyroid. This is an antagonist to calcitonin. Calcitonin, which is secreted by the thyroid, is going to decrease blood calcium when it is too high. So it'll be secreted when blood calcium is high, and it will cause increase of bone density, encourage bone production, which will decrease blood calcium. The adrenal gland has different areas, as you can see here. So first off, in here, on the outer rim, we have the adrenal cortex, and then we have the inner pit called the adrenal medulla. And these areas are important because they're going to produce different hormones. In the adrenal cortex, there are 2 major hormones that are produced. 2 types, I should say. First off are mineralocorticoids. And mineralocorticoids are going to impact mineral concentration. So the main one here is aldosterone. We've spoken about aldosterone, which is going to increase salt absorption. And because it increases salt absorption, water follows. So it increases water absorption in the kidneys. Second, we have glucocorticoids. And glucocorticoids are a everyday stress hormone. An example of this is cortisol. Cortisol inhibits inflammation, it inhibits glucose utilization, it suppresses the immune system, and it is like an everyday long-term stress hormone. In contrast to something like epinephrine, which may be a short-term stress hormone. Another type of hormone that's produced in the adrenal cortex are androgens, weak androgens. So these are supplements of sex hormones. So androgens, in females and in males are produced here. And then in the adrenal medulla, we have the production of quote-unquote adrenaline, which would be our epinephrine and norepinephrine. This is controlled by the sympathetic nervous system. We've learned about that before, and this is activated during our fight or flight response. Glucocorticoids are a long-term stress hormone, as I discussed. And so when you have non-specific stress, it is going to cause the hypothalamus to trigger the anterior pituitary to release adrenocorticotropic hormone to release cortisol in response to that stress. This increase in cortisol will act on either the hypothalamus, well, both of the hypothalamus and the anterior pituitary to reduce their endocrine effects to decrease, to inhibit excess cortisol release. Chronic stress can induce too much of cortisol, and that can cause a few negative effects. It can cause reduced sensitivity to insulin. It can cause atrophy of the hippocampus. It can cause inhibition of vagus nerve activity. It can suppress growth hormone, thyroid hormone, gonadotropins. And so chronic stress can impact growth, can impact BMR, and can impact gonadotropic activity. And now we have the pancreas, as shown in this picture. And we all know about the pancreas and its exocrine activity with the digestive enzymes. But the pancreas also has endocrine activity. And they have these small clusters of cells, as you can see here. The majority of the tissue is exocrine, is those acinar cells, acini. But there are some small clusters which we call the islets of Langerhans. The islets of Langerhans are made out of two different types of cells, alpha and beta cells. So the alpha and beta cells are going to secrete two hormones. The alpha cells secrete glucagon, the beta cells secrete insulin. So let's talk about glucagon first. When glucose is low, so say you're in your 6-hour lab and you don't eat a lot of food during that time, your glucose levels may be low. And what will happen is the alpha cells of your islets of Langerhans in the pancreas are going to secrete this hormone called glucagon. And what that does is it's going to break down glycogen that is stored in liver, as well as break down adipose tissue to release glucose into the blood. And so then this way it will increase blood glucose during fasting. This is a negative feedback loop, right? You start with decreased glucose and you increase blood glucose with the help of glucagon. Insulin is antagonist to this, and so it's going to do the opposite. Beta cells within the islets of Langerhans secrete insulin, and they secrete insulin when glucose is high. And so say before you went to the lab, you ate a really big breakfast at McDonald's and you had really high glucose for some time. And what happens is beta cells of the islets of Langerhans are going to secrete insulin. And what this does is it promotes entry of glucose into cells. And you can see that here. And so here we have insulin bound. And what that does is it releases these vesicles that carry these channels that allow for these GLUT4 channels that allow for glucose to enter the cell. And that way it's going to take high glucose and reduce that glucose. So again, it is a negative feedback loop and it is antagonist to glycogen. Glucagon, it is antagonist to glucagon. Perhaps you've heard of diabetes, or perhaps you know of somebody who has diabetes mellitus, and there are two types here, type 1 and type 2, as you can see in these images. And so diabetes mellitus is marked by a decreased insulin effect, and this can cause hyperglycemia or glycosuria. Type 1, and so as we discussed before, here is a healthy pancreas releasing insulin from the beta cells, and that insulin receptor allows for uptake of glucose. So high glucose now is reduced to decreased glucose. In an individual with type 1 diabetes mellitus, their pancreas does not produce insulin. And so what that means is that there is high glucose in their blood. Their pancreas does not secrete that insulin, and so that glucose doesn't get taken up. And this is caused by a loss of beta cells, and this can affect children because this can be a genetic disorder. So, and this can be caused by an autoimmune disease. And so these patients are dependent on insulin. They have to purchase insulin. And, the insulin has been in the news a lot lately because it's really expensive in this country when it doesn't need to be. You can go to Mexico or Canada and it's much cheaper. Type 2 diabetes, unfortunately, their pancreas releases insulin, yet their tissues have a decreased sensitivity to insulin. Their receptors do not respond to insulin as effectively as they should. And so what that means is that they may need more insulin than normal. And so these individuals, they may have to watch what they eat because they don't have the mechanism to be able to decrease their blood glucose levels. Finally, we're just going to talk about a few other miscellaneous glands in their hormones. The pineal gland, which is kind of posterior to the thalamus, and there is the suprachiasmatic nucleus of the hypothalamus that releases melatonin. Melatonin is what gives us our sleep-wake cycles, our circadian rhythms, and this is it's regulated by light and dark changes. And so, I just had a baby, and babies don't have this production of melatonin yet. And so you really need to teach their SCN of the hypothalamus to do this by exposing them to bright daylight during the day, and then when it's nighttime, making sure that it's really dark so that their pineal gland releases melatonin when they should at night. Because it is inhibited by light. It won't be released with light. And so when it's secreted at night, that makes you go to sleep. That you can take artificial melatonin. That's one way to make sure you go to bed. It synchronizes our physiology with sleep-wake cycles and seasons. It has anti-gonadotropic effects in some animals, and in humans, in excess, it can delay puberty. The thymus secretes hormones that regulate the immune system, that produces our T cells. And then last we have our gonads, or our placenta. Our ovaries produce estrogen and progesterone. Our testes produce testosterone via those interstitial cells. And our placenta, when a female is pregnant, produces estrogen, progesterone, and also HCG, which stands for human chorianogonadotropin. And this is actually what encourages or continues implantation. It discourages the endometrial lining from being shed in implantation. And it's also what is read when you take a pregnancy test. So when you take a pregnancy test, you pee on a stick, and what they're looking for is this human chorianogonadotropin.